Hello, everyone. Thank you for finding your way down the hall. I hope that you have all enjoyed our morning sessions and a very quick break. My name is Leslie Mahaney, and I am an Education Programs Manager here at Nord. I am also a certified child life specialist, so it is my esteemed honor to introduce this incredible panel. As a child life specialist, I worked with many families through their palliative care journey, so really honored to be here today. I want to get us started and introduce this incredible panel. Moderating this session, we have Dr. Danielle Doberman, who is the Clinical Medical Director for Palliative Medicine at Johns Hopkins Medicine. And you will see on the slide we had a little bit of a change today. Due to a family emergency, unfortunately, Shannon could not be with us today. However, in her stead, we have the incredible Melissa Firms, who is a social worker with over 25 years of experience working with children with cancer and serious illness. She is also the founder and president of Kids Need More. And joining her on stage is also Beth Papanastasio, who is an incredible rare mom to Lily and to Bella, and who has experienced the benefits of palliative care services firsthand. Thank you all so much, and I'll hand it over to you.
Thank you, Leslie, and the entire Nord team for inviting us to share our experiences on this important topic. We are hopeful by the end of the session that we will help people understand the difference between palliative care and end-of-life care or hospice, describe what are the goals of palliative care treatment plans, and explain how specialist palliative care can be incorporated into all the other care somebody is experiencing. So first, a question. I don't know if anybody... We can because of time, we can have people think in their head. What comes to mind when you hear the phrase palliative care? And I think start with that. Hold it. Yes. End of life. And right. I think that's what we did with my mom. I had no idea there was any such thing until 2 weeks ago. Right. So palliative medicine is a new field because years ago in the cancer movement, people said, why can't we have this very personally focused, patient-centered, symptom-directed care earlier in our illnesses? And so the specialty has really only been around since the early 2000s and has been recognized by American Board of Internal Medicine in 2006. And maybe, Beth, if you wouldn't mind sharing, when you first heard the phrase palliative care, what came to mind for you?
Sure. So my daughter was in the NICU for about a month when she was born, and we were waiting for her diagnosis. And during that time, it was at Children's National, and it's called the PANDA team, which is the palliative care team. And I had no idea what palliative care was or meant or what it entailed. I kind of just felt like they were people at the hospital that were kind of helping us, but I didn't realize that was an actual like department and specialty, and that they would kind of be able to guide us through the process. So as Bella got older, we learned more of how they could help.
And do you want to share a bit more just about your family and the context, and Bella herself, and when you started to realize the physicians were coming to you with information that wasn't what you wanted to hear?
Sure. So about 2 weeks after she was born, we received her results of her genetic test, and it was pontocerebellar hypoplasia type 6. It's a neurodegenerative disorder underlying mitochondrial metabolic disorder. So they gave us an 18-month prognosis, and in our mind, that was like, okay, we're going to take Bella home, and we're going to spend as much time with her, and she's not going to be with us very long. So we were kind of told about palliative care and hospice, but we figured, well, we'll just take her home and do what we can, because, you know, we're not going to have that much time with her. And the doctors know what they're talking about, and, you know, she is just... We'll just do what we can and be the best parents, give her the best life that we can ourselves.
Thank you. So what is palliative care? There is a definition that our field embraces. CAPCE is called the Center to Advance Palliative Care. They have a lot of resources for family members and individuals dealing with serious illness. And this is the definition embraced by all providers. So palliative care is specialized medical care for people living with a serious illness. It's focused on providing symptom control and quality of life for the entire family unit. So the goal is to assist with communication for all. Palliative care is usually provided by a specialized team, and we'll go over that a little bit more, who work with people's other providers, doctors, nurse practitioners, what have you, to improve quality of life. I think what's also most important is palliative care is based on the needs of the patient and family. So it's not linked to any diagnosis. It's if somebody has symptoms, if families have a lot of challenges coming up with medical decisions as the next step in a care plan, then palliative care meets those needs. It's not based on patient's prognosis, just to underline that a bit more. And it's appropriate at any age or any stage in serious illness. And we like to walk alongside those who are seeking cure and just help with everything with quality of life. There are now neonatal palliative care programs around the country when women are given information on fetal ultrasound, and those programs will walk through a birth. So independent of age and stage. So how does palliative care impact quality of life? So one of this is, the way our specialty is framed is to have more time to sit and go over family questions, lots of family meetings, family counseling. We're all experts in communication, and we also, those who are the doctors, the nurse practitioners, and the PAs on the team can help with expert symptom management. I think one of the other very unique things about palliative and how it can impact quality of life for a whole family is that one of the goals of palliative teams is to assist with coordination across settings. So a patient transferring home with home care needs, a patient coming back to the hospital who was followed in the clinic. Just reducing that anxiety of familiar faces and not having to tell a story again can impact quality of life. Teams also try to focus on what's called anticipatory guidance. So just as somebody might say, your child's about to crawl, you need to put plugs in all the outlets, palliative tries to focus on providing anticipatory guidance of what is to come. So a palliative assessment focuses on mind, body, and spirit, all the domains of where somebody may be experiencing or a family may be experiencing distress, as well as social and financial issues. We have review of systems. We ask methodic inventories. The social workers, the chaplains, everybody has methodic ways that we evaluate people. And more importantly, again, the patient is the entire family, and everybody's needs are assessed. So siblings, grandchildren, whoever that family unit is, palliative teams aim to address distress in everyone. I don't know, Beth, if you'd like to add anything about the family unit of care?
Yeah, so having palliative care has been the best decision for Bella and for our entire family. And that's not only my husband and my other daughter, but like my mom, my mother-in-law, they also have benefited from like the social worker providing support, just almost counseling sessions in our house. Lily gets a child life specialist, comes and plays with her, kind of tries to talk through some issues with her. She's only 4, so she doesn't fully understand yet what's happening, but they have kept Bella out of the hospital several times. Like, she has symptoms that we're wondering, can we deal with this at home? Because we do have kind of a small ICU set up in our living room for her. But they'll come and check her lungs and say, okay, I don't think she has pneumonia, let's try this. And it prevents her from having to go to the hospital. As far as other things the hospice does, a lot is for Lily and Bella, but there'll be like surprise gifts on the holidays. The Easter Bunny just came to visit. Santa comes with elves, just knocking at the door, which is always exciting for little kids. There's volunteers who come. They can sit with Bella while I run some errands, if I need to go to the store. I mean, overall, the services just have improved the way that we can care for Bella, and kind of gives us like a confidence boost too, because it's, you know, they help kind of guide us in the way that we care for her, and also taking care of ourselves a little bit is also beneficial to everyone.
So what's on the screen now are some of the disciplines that commonly make up palliative care teams. Depending on where a patient or family might receive palliative services, whether it's in the clinic, in the home, or in the hospital, the teams might be composed slightly differently. So not every team may have a pharmacist, for example, but many teams within cancer centers do have pharmacists. I think it's especially important to call out chaplaincy, child life, and then integrative therapies. Many palliative teams will endorse and suggest integrative modalities, especially for anxiety and pain. Melissa, I don't know if you want to speak to the social work experience on palliative teams, and then also a little bit of needs of the family and child life.
Yes, and I think, I'm so glad to be jumping in here today. We're actually over running the daycare center where the kids are being dropped off. I'm a social worker that works outside of the hospital, but I get to work get to meet a lot of the folks that do work in the hospital. And I'm a camp director, so I run a camp for children with cancer and their siblings, and also a camp for children that are coping with serious medical needs and in their family. And as a social worker, looking at all of the, just looking at those campers when they're being referred to me and like working with the team, I see the family. I'm seeing the family, and I'm seeing the family and the future for that family. So when I'm laying it out, I'm not just looking at like what's happening tomorrow, but I'm looking at this family over the next 10 years. Well, how is this family going to cope, and what kind of coping skills are they going to learn? The siblings, the parents, the marriage. Like, there's so many other layers going on, and I want to see this family learn to minimize this trauma and find resources. Like, that's my job, is to know as many resources as possible. That, we're talking about the Easter Bunny, that could be a really important service. And there is probably a lot of very specialized services that you wouldn't even think of. Like, maybe there's a beekeeping weekend for your family, or something that's offering, or something that's there for you that you might not know. So this is like my job, to have those resources in my pocket that maybe I can refer to you, that can link you to those things as a family, to help minimize the trauma that you're all going through, and help build coping skills for the future.
Thank you. So what are some common reasons that a patient or family might be referred to palliative teams? These are just some large buckets. One is if it's important, if treatment is at a crossroads. Do we do the treatment or not? Do we do treatment A versus treatment B? So discussion of medical treatment options, and then the phrase goals of care, which we'll get into a little bit later. And the disciplines which often support families in these discussions are in parentheses. Of course, pain and symptom management, the practical supports of an illness, maybe getting financial items in line, guardianship in line, general paperwork, and then, of course, spiritual distress. Oh, yep, I'll go back, yeah. There you go. You got the picture? Okay, good. So another question is, can my doctor do this, right? Like, do we need this other team, or is this just more people coming in and out of the room or in and out of the clinic? I think it's important to say, yes, there is a lot that generalist pediatricians, geriatricians, neurologists, et cetera, can do. So in this table at the top, you see what some people call primary or generalist palliative care. And many providers many clinicians are very good with discussing prognosis, handling some symptom management. It really is kind of when things get more complicated, when illnesses get more complex, it might be time to consider a palliative consult. So maybe there's disagreement between the physicians. Maybe there's disagreement between the family. So those are things that a team of people looking at the totality of who a human is, mind, body, and spirit, can sometimes help families wayfind through. Beth, in your experience with the medical teams, did you feel that Bella's, I want to say, frontline physicians were good with palliative, or how do you feel the experience is now that this extra layer of support has been laid on?
So her specialists were amazing, with the things as far as curative type care and treatment. But luckily her genetics doctor is actually on the PANDA team, so she kind of had a very important role and could help with a lot of the palliative care, questions. But I would say her other specialists, they didn't know of all of the resources, the organizations, support groups, things like that were out there for families and, of kids like Bella. So definitely adding that palliative care team helped just kind of expand our knowledge about what we could do for ourselves and for Bella to give her the best quality of life.
So the top part of this figure with kind of the big orange bar and then suddenly a brown box, this is the historic way that people have conceptualized palliative care. So palliative as end-of-life care, as our audience member said. So you get all your curative treatment, and then someday people say, this is not working, let's change our focus. And often there's a referral to hospice. The bottom is the new view. So you can see that there is our orange triangle and our blue triangle intermeshed. So from the time of diagnosis, palliative teams can do varying degrees of support. Maybe people just want assistance with advanced directives. But as a disease evolves, as an illness continues, there might be more needs. Maybe there's now symptom needs. So palliative tries to walk alongside people who have been given diagnoses that are challenging or who have serious illness. And then the last triangle to the far right is bereavement care. So if families choose to enroll in Comfort Care Hospice, hospice often has bereavement services for the first 13 months for family members. So through every major life event, anniversaries, birthdays, and then 1 month. So that's a value added compared to just care directly from primary doctors. I'd also like to just call attention to, unfortunately, insurance issues. So hospice is a Medicare benefit. For some people, it's restrictive. For people who have commercial insurance, many times there's actually the door's more wide open. There's many times serious illness plans for people with commercial insurance that will allow things like chemotherapy and hospice. For children, Medicaid, of course, drives, and each state is very different. And in some states, Medicaid fully supports palliative services. Hawaii passed a bill last year. California's had it for years. So I would just say, if people are starting to discuss palliative care, look at your insurance, figure out what may be there to support you. Do you have an insurance case manager who also can work with the palliative teams or the hospital teams? There are opportunities that may be available that are unknown to family. So I don't know, Beth or first, and then Melissa, if you'd like to just speak to insurance at all.
Sure. So we had TRICARE when Bella was born, and at that time, TRICARE would either cover curative care or hospice. Those were the options. And so we weren't ready for Bella to be in hospice, so we just had curative care. And then, not really sure why, maybe a year or two later, we decided, let's have Bella start hospice. So we were driving to the hospital and we get a call en route, and they said, well, your insurance isn't covering this test today. And I said, well, why not? And they said, well, because now you have hospice, you don't have curative care, the plan you had before. And so, palliative care, hospice, curative care, I don't know. I'm this new mom. Why am I thinking about these things with my newborn? Like this is crazy. I don't know what these terms mean. So we were not informed. Maybe it was our fault for not asking the right questions, but we were not informed that, okay, when you move to hospice, you do not have these other services, or you need to get, I don't know, referrals from different doctors, like your hospice doctors now. So when we learned that, we quickly dropped hospice and went back to the curative care. But then we later found out, I think Bella has received palliative care services since she was about 5, and she's 7 now. So I'm not sure at what point TRICARE started allowing the concurrent care, but the reason we started palliative care for her was because her seizures started getting worse and it was harder to keep her out of the hospital. So, we really don't want to be spending all that time there. So we were able to start palliative care. But what I would suggest is just that you really ask those questions, that you really understand what your insurance is going to cover. Unfortunately, we have to rely on that because it's so expensive. But just understand, as best that you can, and ask your care team and your insurance specialists, what benefits or what services can we get from palliative care and from the services that are available to us.
I think we're going to do questions at the end. If you don't, it's okay. I'm going to just actually go to this next one and ask you as an audience, how many of you are familiar with the phrase goals of care? So a little bit. Okay. So goals of care are where is our treatment plan going? Are we looking at fully just curative? Are we trying to balance quality of life, or are we fully in a comfort care zone? And many times patients will have goals. I want to maintain my dignity. I want to maintain my independence. I want to be able to continue to walk. Those are goals that we, as physicians and other healthcare providers, try to match the therapeutic care to achieve the patient's goals. Maybe it's live as long as possible. Great. Maybe it's live as long as possible, but if some of these treatments are too onerous or could diminish my function, I may or may not want them. And so the concept of goals of care is what's important, what are the values that are important in your life that you hope to maintain? This is a framework for thinking about it, 3 big buckets. So prolonging life, maintaining function or quality, and then comfort care. And you can want 2 things at the same time. The 2 circles to the right, maintaining function and comfort care, are when it might be that a patient and family's goals align with a palliative treatment team. And I know, Melissa, you were going to talk a little bit about the wisdom that some campers have shared with you over time with regard to this.
I have to say that I work with these kids that had serious illness and cancer for many, many years. And I really felt like I had a handle on some of these things that we're talking about. And like maintaining function for a kid really is like maintaining like play, right? Having a good time, living. Kids don't know what they don't know, what we know. So they're living and they're really in the moment. And so being able to maintain their ability to have those best moments, to be able to create those memories, be able to create those core memories. Later on, I got leukemia. Apparently you can get that. Apparently you can get that even if your camp director works with kids who have leukemia. And I had to get a stem cell transplant. I had GVHD, and now I have, IPF. So I have, the lung disease that's continuing, and it's from my treatments and everything, and my graft versus host. And so, who taught me the most? the kids and those families that have been doing palliative care all those years. And even the families that have gone on, that may have gone through losses, that have gone through palliative care, and now there are maybe 5 or 10 years out there coming to me. They're the ones that are giving me the best wisdom. Gina, who has been my camper, who's having brain tumors since she was 7 or 8 years old, and now she's 20, and she says, Melissa, this can't change. This is not. Don't let this define you. There still needs to be joy in your life. I know you know how to do it because you bring it to others. I know it's still there. So it's this. We see so much more of you than this. There's got to be more to you. So it's really like that. I see that part is that. Of course, we're going to prolong. I want to prolong my life. We want to prolong our lives, but where's that quality piece? But quality piece to me is about finding that joy, and I think about. Especially when you have think about young families, think about kids. When you're 6 years old, you can't do 6 over. When you're 36 and you get sick, you can do 36 again if you had a bad 36. You have a bad 36. You can have a good 37. You can feel better. You can do it again. You can do a repeat. You can't redo 6. You can't redo 6. It's a core memory. It's a core memory that you're creating. You're creating these memories during this time as a family that are very, very important. They might seem like small. To a typical family not going through stuff, those things don't really matter. You can go through moments and they don't matter. Certain holidays or milestones, and you don't even miss a beat if you're a typical family. But when you miss those things during trauma, those are core memories. You can't get them back. So it's like trying to it's like a treatment plan for coping with that trauma is how I kind of see it.
These are some questions. Many times families will say, I get into that medical interview, I don't know what I can ask, what can I advocate for? And I think of palliative care as informed consent. Does the patient and family have all the information they need to make decisions that align with their goals? And so I would recommend, if you ever find that you're at crossroads, share these questions with family and friends. What is the best case? What is the worst case? And what's the most likely case from where we are? What are the probability of these outcomes? What could prognosis be both for longevity and function, both with and without the treatment? And then doctor, nurse practitioner, PA, whomever, will this achieve our goal of keeping mom home, keeping so-and-so out of the hospital, et cetera? Because that's ultimately what palliative wants, is to align care with patient and family goals. It's very challenging to live with an illness where things are gray. And I don't have to explain that to this group, but that's one of the other things that palliative care tries to do through incorporation of social work, chaplaincy, child life, and others to help deal with the stresses of having something that doesn't fit inside a textbook. And I think to understand that many times, especially for rare illnesses, the textbooks have information from 10 years ago, and the cutting edge is sometimes clinical trials that are going on right now. And so it is hard to sometimes have humility as a physician to say, I don't really know the whole prognosis, but this is what I have on paper. So palliative says, let's hope for the best, but we'll prepare for the worst and live with both of those ideas together. Sorry. I had rearranged the slides. Hold on. I had rearranged the slides. This is our... we were going to talk a little bit more about Bella's story, Beth and her family's journey, and kind of, we've been talking about a lot of the benefits of palliative care, but just before Q&A, are there also some drawbacks at all to having these services?
Sure. So definitely more pros than cons, but there are a few that you have to consider. With palliative care, there are people in your house often, so there are requirements from different, it's actually a hospice service, but we use the palliative care part of it. They have requirements, so a nurse has to come once every 2 weeks. A social worker has to be involved because they're ultimately your case manager. There's a chaplain if you want there to be. There's a child life specialist. So all these people are great, and they provide all these wonderful services for your family. But sometimes you just are kind of like, okay, another visit. Somebody else has to come, because we also have nursing through a private nursing company. So there's just, it's like, okay, what's today? I'm looking at my phone, like, who's coming today? The teacher's coming, the nurse is coming, there's always somebody coming. And so you can pick and choose that. I mean, if you want the basics, you can just take what you want, and they're totally fine with that. So that's kind of the only downside that I can think of. Definitely, like I said, the pros, I mean, there's so many benefits to it, and I really encourage you to look into it because it has been so helpful for our family.
Can you speak a little bit also to your Facebook group and just the support of others in kind of the parenting community?
Yeah, so when Bella was born, there were supposedly 9 cases in the world with her condition. And of course, there are probably more, just not diagnosed yet, but sorry, I lost my train of thought.
No, just the Facebook community.
Oh yeah, and so I'm sorry. The doctors told us, I mean, it was so rare. Like we thought, okay, nobody can help us. We're totally alone in this. Who do we go to? Let's just hunker down at home and be depressed. And so about a year into it, I thought, you know what? Let me just do this little search on Facebook. And so it turns out that there was a kind of a parent support group for pontocerebellar hypoplasia. And there's a lot of types, but this was a group for all the types. And that has been the biggest support, I would say, to me, because their family's going through exactly what we're going through. They honestly sometimes know better than doctors what medicines work, what seating is best, what positions are best. I mean, it is just an amazing group of people, and it's international. So, there's people from all over. And I didn't find that from the doctors. The doctors didn't tell me, nobody told me. You kind of have to go out there and look yourself. But I also encourage you to try to find those groups, because, I mean, I didn't think they existed. But then, a quick little search, and I was like, wow, they're here. So hopefully there's one out there for your condition as well.
I will say, I had a patient 2 or 3 years ago at the hospital just before COVID started, and the adult daughter, the mother had been diagnosed with a brain tumor. The adult daughter came in, brand new diagnosis, 3 weeks, and she said to the oncologist, "We would like palliative care." They said, "Why?" She goes, "I don't know. I'm on a group on the internet, and they all said, you must have palliative care, you must have it early, it's the best thing for the brain tumor." And so the social worker and I went to go visit the family, and they said, "We don't know what you do. We just know we're supposed to have you. So can you please explain?" And then the other thing that they said was very interesting and very common. The oncologist says, "We don't need you yet." The radiation therapist says, "We don't need you yet." And it's, again, this unfortunate linkage of the phrase palliative with conflating it with comfort care, end-of-life care. And they were persistent and got a consult because they said, we've seen through our support group, this is helpful. So I think we're going to start the Q&A now.
Sure, thank you. My name is Mary. I'm here from the NORD staff, and we do have some questions that have come in both from people here in the room with us today and from some folks in our virtual audience, so we'll get to as many of those as we're able. The first question that came in is, how do we communicate with our doctors about our desire for adding palliative care when they assume that that means we are giving up? And also, how do we get palliative care in areas where the only palliative care doctors are affiliated with hospice? So around the country, many hospices now have
what they call palliative arms or bridge visits. And so it does unfortunately link the two terms, palliative care and hospice, together. But the symptom control training, especially for physicians and nurse practitioners, PAs, is the same. And viewing somebody through the lens of a total family is what hospice does. So I personally wouldn't be afraid if the palliative services come through a hospice company. They actually have to have different Medicare ID numbers. They keep them separate arms. And I know your services come, most of the pediatric services are under the umbrella of hospice companies who've been doing home care for a long time. In terms of speaking to physicians, I do think, as with everything, advocating, it may be just finding the right physician to make the referral. It may be asking your insurance case manager. It may be some clinics I know have social workers embedded in the clinic, asking the social worker if you could have a consult by palliative. Sometimes physicians will tell me when they hear a family saying, we want palliative, the physician hears, you're not enough for us. You're not doing a good enough job. So I think to say, I have more questions, I want outside experts, I want more support, we want you to be part of this team. We're not giving up, but we want more information, and we're wondering if and when focusing more on quality will become important.
Thank you. And we have another question. What makes palliative care for children different from palliative care for adults? And can you explain concurrent care?
Well, I can explain concurrent care. So it's just when you're not solely receiving the curative care, which is like your traditional insurance or medical coverage, and you're not on hospice, where you essentially have a whole separate set of doctors. So I think this is more common for children. And again, I can speak to only children really from my experience. But so now Bella we can take her to the doctor, and she can see her regular genetics doctor, her pulmonologist, her cardiologist, all the doctors. But we also have these palliative care services at home, and they're both being covered. So that's what concurrent care means.
So Medicare regulates hospice. And so each individual hospice can choose if they want to pay for intravenous antibiotics, IV fluids. Many hospices will pay for ventilators for patients with ALS or other illnesses. Not all. Small hospices can't always do these more advanced therapeutics. If a person has commercial insurance, there's often what's called a carve-out, which will allow the insurance to keep paying for the advanced therapeutics when somebody enrolls in hospice, and that's usually a concurrent care model for serious illness. Pediatric patients, Medicaid allows that from the beginning. So Medicaid doesn't put limits in most states. They will allow patients to have artificial nutrition in the home, artificial fluids, ventilators, and to freely go back and forth to the hospital. There are some private insurances that also allow patients to go back and forth to the hospital, have chemotherapy, have radiation, go back to the ICU. I think children, it's always concurrent care. Adults, it's concurrent care depending on your individual insurance and the hospice agency, if you've enrolled in hospice, that may be paying for things. Palliative, separately, palliative is like going to see the gastroenterologist. The way the visits are billed and the way providers are structured in clinics is like every other medical specialty. So you can have a palliative visit and do all your other things, but it might not be the depth of services with current care.
I just wanted to speak to one thing. You know, I'm a little more regional, so I don't know about the insurance pieces across the country, but I could say that there are things that are outside of that. There are lots of individual organizations that are providing these things for you to look for that could be something that you could take advantage of for your family, that you would be in the realm of palliative care. You know, there could be therapeutic horseback riding or something that's available to your family, or other organizations that want to give you some wraparound family services.
Do you have tips for regulating or normalizing conversations with others long before they need it? Death stigma often leads to not understanding things like palliative care until it's needed.
Yeah. I don't know if I can show the slides again. Oh, microphone. I don't know if I can show the slides again, but there's a wonderful website called the Conversation Project, and it's free. And they have, I guess, I can show the slides again. Okay. This Conversation Project. So this was set up by the author Ellen Goodman. She was in the ICU with her mother in the 80s, and the physician said, "What does your mom want?" And she froze. She never had the conversations. How do you have these conversations? And so she started this resource of question and answer that neighbors can do this. It's set up for families to talk to each other. And there's a lot of resources on this website of how to set up the conversation, when do you have it. Everybody at Thanksgiving dinner, everybody just fill out a living will. You know, just normalize this for everyone, because unfortunately, these questions come up at some point in everyone's lives. The other resource that I wanted to show was this. Prepare for Your Care is an online advanced directive living will that's free. It doesn't require a notary. And it also has a lot of these more quality of life questions interlaced with medical treatment decisions. So this is also, it's a very readable format, and it was made by a lot of community for community. I don't know if there's another question. Oh, I guess we're all done.
I know that we received a lot of many questions, and I'm sorry that we can't get to all of them. We are very lucky to have our VP of Patient Services here in the room. So if you have specific questions about your family or loved one, please reach out to NORD's Information and Resources Services. They can be reached at informationservices@rarediseases.org. So I just want to thank Dr. Doberman, Beth, and Melissa so much for this incredible session. And Beth, thank you so much for sharing Bella and your family's journey with all of us.
You're welcome. Also, sorry, I just want to say, if anybody has specific, like if you just want to know what kind of services we've been able to take advantage of. I live in Virginia, so I'm just, feel free to email me. I think my email's up there. But you know, I can't help get you services or anything like that, but I can just try to share with you some of the things that have been really helpful for us that palliative care has pointed out and led us to. So please feel free to contact me whenever.
Thank you so much.